Eugene Reynolds, age 62, one of 700,000 Americans that will fall victim to a stroke this year. His chances of recovery depend on just how quickly medical attention is received. What causes strokes? And what can you do to decrease your risk of becoming victim number 700,001?
Your body is in good shape. You don't get infected.
Exercise is extremely important.
Diet is not
everybody is vulnerable to addiction.
Epidemic of obesity.
Fries and a burger, it's the way to atherosclerosis.
Cancer is going to become the number one
Spend
killer.
over everything you can on healthcare.
Stroke is the most common sudden injury to the brain, the third leading cause of death in the United States after heart disease and cancer. It is the principal cause of adult disability and a common reason for people to be placed in nursing homes. In human terms, what is a stroke and how can it do so much damage in a relatively short period of time?
A stroke really is an attack on the brain. A stroke is a damage to the brain due to blocking or rupture of a blood vessel leading to the brain. And in a stroke, either the brain is suddenly deprived of blood flow because an artery has been clogged, or an artery has ruptured and blood is escaping directly into the brain.
Stroke is an age-related disease. Most of its victims are middle-aged and older.
Incidence of stroke approximately doubles for every decade over the age of 45. 2/3 of all strokes occur over the age of 65. But stroke is also not uncommon in mid-adult life or even in childhood. And there are more strokes in patients under the age of 45 than there are cases of multiple sclerosis.
The risk factors for stroke, in certain respects, resemble the risk factors for other cardiovascular diseases.
Well, high blood pressure, hypertension is the number one modifiable risk factor for stroke. High blood pressure increases the risk of stroke 5-fold compared to people who don't have high blood pressure. The conventional definition for high blood pressure is having a systolic blood pressure, the upper number, that's 160 or higher, and the diastolic blood pressure or lower number, that's 85 or 90 or higher. If you have blood pressure in that range, then to work with your physician in lowering the blood pressure. Usually the first steps are lifestyle changes, doing relaxation, identifying stressors in your life and removing those, and dietary interventions. Many people have salt-sensitive high blood pressure, and reducing dietary intake of salt can reduce their blood pressure. If the blood pressure remains elevated despite these non-pharmacologic treatments, then drugs can be very helpful and very well tolerated. High blood pressure has been called the silent killer because people get no symptoms from it while it's slowly producing all this damage to blood vessels in the heart and the brain.
High cholesterol is also thought to be a factor, although major epidemiological studies have not supported this premise.
However, there are now many cholesterol treatment studies that have shown that treating patients with elevated cholesterol can reduce the risk of stroke, and therefore there's pretty convincing evidence that cholesterol is a risk factor for stroke. The most important of the cholesterol numbers probably is the LDL cholesterol, the low-density lipoprotein cholesterol, so-called bad cholesterol. And we recommend that individuals have a fasting LDL cholesterol that's less than 125 as a target if they've never had heart attacks or strokes or any events in the past. If they have had symptoms in the past, then we aim even lower for an LDL of less than 100. We've been getting this.
Homocysteine, a byproduct of normal metabolism, is also emerging as a risk factor for stroke.
Now there's pretty convincing data from over 20 epidemiologic studies in large populations that mildly increased homocysteine does increase your risk for heart attack and stroke. The exciting thing is that homocysteine is potentially easily treatable. Taking extra doses of the vitamins that are involved in the metabolism of homocysteine, B12, B6, and especially folic acid, can lower homocysteine levels with extra intake. And so a number of clinical trials have now been organized to see if taking extra vitamins and lowering serum homocysteine does result in actually preventing stroke and heart attack. If so, it will be another important addition to our stroke prevention practices.
It was a summer of promise for Karen Christensen and Ken Jones. After 10 years of marriage, they were expecting their first child. Ken was teaching when he got the call.
It was a person from the Y, and when they first started talking about Karen, it was very strange because I thought it was going to have something to do with the pregnancy, and then when they said it was a stroke, it took a few minutes for it to kind of sink in.
I went to the class, and that's all I remember. I know now that the teacher, she saw that I wasn't acting as normal or whatever that the other women were.
The source of the problem was occurring inside Karen's brain, the body's control center.
The brain is an incredibly complex organ. It's the seat of the personality and thinking in our humanity. It has millions or perhaps billions of nerve cells and billions upon billions of connections between these nerve cells. It is organized in a very regular pattern from individual to individual. It is fed by a number of blood vessels that bring nutrients to different areas of the brain. The brain is about the size of a basketball, a little smaller. It has the consistency of toothpaste. It floats in liquid that helps to protect it from the minor buffeting we get every time we take a step. And it is, of course, encased in the hard skull in order to provide protection against injury.
What clues or warning signals suggest that the brain is under attack, that someone is experiencing a stroke?
Whatever the brain can do, which is everything we do, it can do wrong if that part of the brain has been damaged. So the symptoms of a stroke can be virtually anything. There are, however, certain major themes of brain action that are impaired when a stroke occurs. The warning signs that the American Heart Association is educating patients to look out for include sudden weakness on one side of the body, sudden numbness on one side of the body, sudden difficulty speaking, sudden trouble with vision, sudden difficulty walking, or sudden severe headache.
Just having one of the symptoms may not mean a stroke is in progress, but if one of the symptoms lasts for 10 minutes,
Houston Fire and Ambulance, what's your emergency? Stroke? Is he able to move his arms and legs and talk as usual?
then at the 10-minute mark you should call 911 or be driven directly to the emergency room. Don't waste time trying to reach your doctor or reach Aunt Minnie, who had a stroke 10 years ago and is the family expert on a stroke. Call 911 and come directly to the hospital. That's the only way we have a chance of getting to patients in time.
We have a 54-year-old white female, 54-year-old white female, possible stroke.
In the past, before doctors had the means to check the damaging effects of a clot, stroke victims were not considered a priority by paramedics or emergency personnel.
Now that we have proven interventions available, that attitude is changing, and more emergency medical systems are recognizing that stroke is an emergency that should be treated as equally important as heart attack or trauma or any other level 1 priority. And the same with triage nurses and other decision makers in the emergency department after arrival.
You go to the chest pain center, you know where that is? Okay.
Ken arrived at the hospital an hour and a half after Karen. Within minutes, half a dozen specialists rushed him through a maze of corridors to her side.
Just pumping me for information, background information about Karen, and we're trying to be very calming as well. As we spoke, she was having an MRI and a bone scan. You know, basically they were prepping her and describing to me what this procedure they were going to do.
the probe will come
In the past, our treatment decisions were guided by deductions from the neurologic exam as to what was happening in the brain, rather than directly visualizing the brain process itself. But with diffusion-weighted MRI scanning, we can see changes occurring within minutes of the start of low blood flow. And we can make a decision in an individual patient that is tailored specifically to what's occurring, to where in the brain the ischemia is, to how large a brain region is being threatened, and to what the mechanism is that's producing that injury to the brain.
MRI scanning verified that Karen was experiencing an ischemic stroke.
In this type of stroke, blood clot has blocked blood flow to a region of the brain. Not enough oxygen and nutrients are reaching nerve tissues, and the tissues die as a result. TPA is a proven agent for the treatment of ischemic stroke. It is a clot buster. It reopens clots that are blocking blood vessels and restores blood flow to threatened regions before irreversible injury has occurred.
One of the main surgeons felt it was very important that I see her right before they started the procedure. And so they took me in, and they were just very quickly preparing her. And so at that point, she couldn't speak. She couldn't say anything. We didn't have more than a minute, and Karen doesn't remember anything. I just went in and tried to pretend that it was no big deal, and I was like holding back tears and stuff.
Time was critical in the use of the clotbuster TPA to counter the effects of Karen's stroke.
When blood flow is blocked to the brain, a number of processes leading to cell injury begin to occur immediately. And unless the blood flow is restored within a few hours, then the brain that's at risk is irretrievably lost. So unfortunately, we have learned that the time window for intervention in acute stroke is very brief, on the order of 3 to 6 hours. And if you reopen a blocked blood vessel beyond 6 hours, all the damage that was going to occur has likely occurred, and you may even be doing harm by reopening the blood vessel at that point.
TPA procedures are designed to be simple and available at any hospital emergency room which has a CAT scanner.
A patient arrives, you do a neurologic physical exam testing the strength and cognition and reflexes. You do a brain CAT scan to rule out a brain hemorrhage, and then you give the TPA as an intravenous solution over an hour. You follow the patient's blood pressure, and you follow their neurologic exam, their strength and cognitive abilities. But there's no sophisticated monitoring that's required. That allows it to be a simple procedure that's widely available. At specialized centers, there are much more sophisticated ways of monitoring brain function with continuous EEGs, continuous electrographic recordings of brain activity, or with frequent MRI imaging looking at how the brain ischemia is evolving.
The first reports about Karen were guarded. Although the clotbuster had been administered, not enough blood was getting through. The surgical team even tried angioplasty to increase the flow.
While they were able to open up some of the artery and get some blood flow going, the words that stuck in my head were unsuccessful and significant, meaning a significant portion of brain tissue was damaged.
But during that first night in ICU, it became obvious that the clot-dissolving medication was continuing to work.
It was really a bad night, but then Karen finally woke up, like later that night. It just became pretty obvious to everyone that it had been more successful than they had originally thought.
We were able to reopen the blocked blood vessel and limit the damage from the stroke, but not prevent damage altogether. And for the next 2 weeks, there were many touch-and-go issues having to do in part with how best to go ahead with the delivery and how much of a threat to the mother continuing to carry the pregnancy was.
Karen was pretty anxious to have the baby, but she was pretty anxious even before the stroke. She was wanting to get on with it.
They were actually thinking of doing a C-section, but then they decided against it.
They were all saying the baby's fine, and they even brought up an ultrasound to show Karen that the baby was just fine, but Karen wasn't really going to be convinced until she was here.
The neurology team and the OB team worked together throughout labor and delivery, carefully monitoring Karen's blood pressure and the baby's progress.
So she really felt all of the contractions all through the night.
And they told me never to push.
So finally, the attending physician sort of stuck his head in, saying, "Okay, if she doesn't come in the next couple of in the next 2 or 3 contractions, then we have to go to section." And then the very next contraction, out she came, and
this is Scout Elaine Christensen.
When I saw her, that was wonderful, because they brought her to me, and I had like needles up and down my arms.
The night after the surgery, I was sort of like trying to picture myself as this caregiver with someone who's non-ambulatory, and trying to project how we were going to deal with all that. And well, we didn't. That was a non-issue because Karen was walking.
Yeah, on my right side, the leg and the arm were a little off, but it wasn't that bad.
And the more I talked to people who've known stroke victims, the more I realized what a wonderful thing that Karen got the treatment that she did.
Despite all they've been through, Ken and Karen have found that humor is a great help in recovery.
Karen was calling formula fodder or fodder. She couldn't think of the word for baby formula. Some funny things come out, and that's helpful for everybody to sort of take away some stress.
I can't get the words out. I mean, I know the word that I want, but it won't come out my mouth.
She really has to work at it. It's like learning a foreign language. I mean, the main thing that I have to do is not try to remember not to finish her sentences, but to let her, struggle through that.
Struggle and perseverance. Both words characterize the path to recovery for a victim of stroke. So do the words resourceful and adaptable in referring to the brain itself.
We've learned a little bit from neuroscience about how the central nervous system works and how it might respond to inputs, how it learns, how it adapts. And we can even image some of that adaptation using functional imaging techniques. This is a series of functional MRI scans done at 4 points in time, right after a person had a stroke, a few weeks later, several months after that, and 6 months after that. So this man had a stroke that caused him to have paralysis of his right arm. At the time that we did this study, we asked him to try to open and close his hand a little bit, and he was unable to do that at all. What we see is a tiny activation of the hand area over the area that it should occur in the motor cortex of the brain. But interestingly, we see the opposite side, the normal side of the brain, becoming activated, and some supplementary motor areas, even though he really can't move the hand yet. In the second set of scans, he can now move his fingers a little bit, and what we see is a little bit of activation again in the abnormal side of the brain, the side that had the stroke. And that suggests that both sides of the brain, both hemispheres in the motor areas, are forming a network to try to carry out this task, even though he's still doing it rather poorly. Well, he's still at home practicing for 3 hours a day, pinching, grasping, reaching, and his arm is getting better. And when we look again at the third set of scans, we find that there is a fair activation now in the abnormal side of the brain, the left side. On the normal side of the brain, we see a smaller contribution now as he's getting more control on the side that was affected by the stroke. In the final scan, the hand is moving now rather well. He can squeeze with about 75% of normal force and move his fingers fairly fast in opening and closing them. And we see very little activation now on the normal side of the brain that no longer is needed to be brought into play in this network for movement. And so now as he's learned this task, relearned it using leftover pathways that weren't damaged and driving the plasticity or adaptability of the brain by his consistent practice for 3 hours a day, opening and closing his hand and pinching his fingers, we now get back to a smaller area of activation, more like normal, though still larger than normal, and he now has a functional hand.
5 months ago, Jim Krakowski experienced the second major type of stroke, a cerebral hemorrhage, while he was getting ready for work.
I was awake in the bathroom, trying to wonder, what can I do? All I can remember is you're dead if you try and do that. That's a terrible idea. But I managed to crawl into the bedroom. It was just terrible. I couldn't do anything, and I couldn't dial, because if I dialed anywhere, I couldn't even get the response out. So the only thing I could do was to lay there and be Jim.
When his wife Mary returned home that night, the house was strangely dark.
I kept calling his name, and I was looking all around, and then I looked in the bedroom, and it looked like it was dark in there, but it looked like someone was on the bed, and I started the feeling of panic, and I turned on the light, and Jim was laying in the bed, and he rolled over, and I am yelling his name by this time, and I just saw the look on his face when he finally looked up, rolled his head up toward me, and it was just, I'll never forget that look. It was just, he was so scared.
I remember that feeling of Mary coming home with that work that night. She was the thing that touched me first of all, and she looked at me a little like she was scared for herself, and that's a bad thing to do. So I kind of knew I was going to the hospital.
The hemorrhage was quite large and deep, and the surgeons had to go in and try to remove as much of the clot as they could because he was just deteriorating so fast. He then spent a week or 10 days being extremely lethargic and confused, and developed a little pneumonia and couldn't swallow, couldn't communicate. He came down to our rehab unit once he was at least a little more medically stable.
Initially, the focus was on getting Jim to eat on his own, to sit up, and to understand what was being said.
When he first came down, if I said to him, how many elephants are in the room, he'd nod. Now when I say it, he laughs and, looks at me like I'm crazy.
This is a funny memory. There I was yelling out, I've got this terrible, but nobody hears me. And that seems to be the need I have to be heard, because I could only catch the small bits that would come out of my mouth.
Okay, left arm through like a jacket.
As recently as 3 or 4 days ago, he just had a hard time even standing up.
2, 3, up. Great, very nice.
Actually, much to my amazement, after one treadmill training session, he was able to put weight into the right leg some and control the knee a little bit. He has no feeling on the right side, as well as virtually no voluntary movement.
Stand here.
The climbing harness holds Jim's weight as he is suspended over a treadmill.
Okay, let's start. Great.
We've developed these techniques so that the therapist can optimize what the nervous system sees that's relevant to walking. So speeds that the nervous system is used to seeing, joint angles at the hip and the knee and the ankle, changes in balance, shifting of weight, loading of one leg and the other. By providing as normal sensory inputs as we can, we see that the spinal cord reads this information coming from the legs and the joints and the muscles, sends that information up to the brain, distributed in different parts, and that this helps reorganize the networks for walking.
I was so gratified to be able to get on the treadmill.
So just being upright, just feels great, and it allows us perhaps to prevent a lot of medical complications that might occur when people lay in bed, like pressure sores in the skin, or blood clots in the legs, or loss of muscle bulk. Muscle atrophies very fast. One of the terrific things about rehab is that it's not about being sick, it's about getting well.
Good. That's it. Step.
After a month in acute rehab, Jim came home to continue his recovery efforts.
The one thing I felt is like I didn't have time to think through some of the changes I knew I was going to have to make. One was I had to measure doorways. I had to make sure there were carpets, no loose carpets around, because with his initial walking, he couldn't pick up his leg well enough so that he would be tripping on carpets and things like that. Jim's brother helped build the ramp into the house and helped take the door jamb out of the way of the bathroom so Jim could get the wheelchair into the bathroom so that he could be able to do that himself.
Recovery, as Jim learned, is hard work, and at times, progress seems painfully slow.
And the key to any rehabilitation in patients is to practice and practice those things that you want to do. It's just as if you were going to learn how to hit a tennis ball and play tennis. You've got to practice that swing or you end up playing like I do, which is terrible.
It is hard not to be able to do things for Jim, to watch him stumble through getting his own brace on and doing those tough things for himself when you know that you can do it faster and easier by helping him.
I was pretty shocked that stuff could really drain you as much as this stuff does.
Well, the myth is that people only get better for the first 3 months or 6 months or relatively short time. We can even take a patient who's 5 or 10 years post-stroke who walks slowly still and give them a little burst of therapy and often improve their walking speed by 30%.
Gosh, you're doing that so much better.
With his kind of stroke, we tend to see a much slower course of improvement, but people do improve. He has his youth, his athleticism, all going for him, his motivation, his terrific family. It's likely that given the progress we've seen just in the past few days, that will start to spiral and snowball.
The subway downtown. It's gotten easier. It's not as difficult as it was before. And as it gets, every day goes by, there is less and less pressure on me.
I think Jim and I both feel that this is a team effort, and he's doing the hardest work, but that I'm another component of that, because I feel that we both need to heal from this. We're both on this adventure that we hadn't planned on.
The Human Condition is a 26-part series about health and wellness. For more information on this program and accompanying materials, call 1-800-576-2988 or visit us online at www.intelecom.org.